Thank you everyone for joining in. My name is Ruben Manohara. I'm an orthopedic surgeon with the Shoulder Elbow Orthopedic Group. And today I'll be talking to you guys about reverse total shoulder replacements and how it can help your patients. Now, the reverse shoulder replacement has been one of the most significant advances in shoulder reconstructive surgery over the last 30 years. But unfortunately, the awareness amongst the public and even the non-orthopedic population and group like yourself is still quite low. So I'm hoping this talk will change that. So what I'll be covering today, and is briefly in about the next 20 minutes or so, is firstly an introduction to what a shoulder replacement is about, how the reverse shoulder replacement is different from the previous one or other joint replacements for that matter. And then we'll go through the various clinical indications for reverse shoulder replacement. And then we'll talk about where are we now in terms of outcomes, in terms of the survival longevity, and what's the future direction that shoulder replacements are taking. And then once I'm done my talk, we'll just have the quick summary and the question and answer session straight away follow. Okay, so as you know, the shoulder joint is the most mobile joint in your whole body. You can move it forward, you can move it backwards, you can AD duct and AB duct, swing it towards and away from your body, and you can rotate internally and externally. Or you can do a combination of any of these 6 movements and position your hand anywhere in space. And that's called circumduction. And it's really quite marvelous. It's the only joint in the body can do that. Now, unless you've had a shoulder problem yourself, many people take it for granted that you actually need, a pain-free functional shoulder for a lot of your daily activities. Whether it's washing your hair or getting it styled, whether it's getting dressed, like hooking your bra behind the back or squiggling into a t-shirt, for toileting and perennial hygiene, or just getting a good night's sleep. Actually, even eating or just reaching for your handphone in front of you in the desk all requires painless and smooth shoulder motion to be done. And of course, a lot of the sports and hobbies that we enjoy recreationally or competitively all require, a lot of shoulder movement, and there's a lot of force going through the shoulder, even if it's just cycling where you're stationary or yoga, some of these yoga poses. Now, I'm sure some of you are thinking, why is this guy showing all these, athletic sporty pictures when you're going to talk about shoulder replacements? How would you do any of this after shoulder replacements? Well, the truth is there's actually a lot of literature already out there that, following a shoulder replacement, the return rate to surgery at the same level, if not better, is between 85 to 95%. And there's a lot of literature specifically for sports such as swimming, golf, and tennis, following a shoulder replacement, having good outcomes and good longevity. And you can see like the middle study there shows that, the patient's driving distances improve, the handicaps decrease, and the pain and satisfaction is generally better as well. So it is still possible to have an active lifestyle after having a joint replacement done for the shoulder. Okay, so let's talk about shoulder replacements. Now you see the top row here, that's the usual conventional shoulder replacements where, you have your ball and the socket, and the sphere is on the arm side and the socket is on the glenoid side, just like your normal anatomy. So this is the anatomical shoulder replacements. The one here on the right is a stemless replacement. So you can see without that longer stem, it's more bone preserving, less invasive, easier to revise. And so these are the newer type of implants we're doing these days. This is the reverse shoulder in the bottom row. And the reason it's called the reverse total shoulder is because, as you can see, the ball and socket has been swapped around. So now the ball is actually on the glenoid of the scapular side, and the socket is on the arm side. And I'll explain to you why just changing the ball and socket around changes the whole biomechanics and dynamics of the joint. Now, how is a shoulder replacement different from, say, your hip or a knee replacement? Well, I've already mentioned you have your greatest range of movement in the shoulder, and the glenoid is far less constrained than, say, the ball and socket joint of the hip or the very conforming knee joint. So there are greater shear stresses, and that it's more susceptible to mechanical loosening. And that was a problem that was troubling the initial kind of shoulder replacements that were coming out previously. And the success of the anatomical shoulder replacements would depend on having an intact and functioning rotator cuff. And with time, your own tissues, your rotator cuff may degenerate, may even tear. And so then, your shoulder replacement wouldn't be able to work then. Another limiting factor was you need to have adequate glenoid bone stock, right? Because if there's enough bone, you wouldn't be able to put an implant on. And our Asian glenoids are only about 25 to 30 millimeters in size. So that's not a lot of real estate that we have to work with. So just to recap again, your rotator cuff stabilizes the joint, right? So in both the coronal plane and the axial plane, the cuff helps to keep the ball centered on the socket, and resist the forces of the big muscular deltoid that's pulling it. So once someone has a rotator cuff tear, then that force is unopposed, and then you get the ball moving superiorly and rubbing against the acromion or the roof of the shoulder, rubbing against the top of the glenoid. And even a normal shoulder replacement would not be able to overcome this imbalance here. So now you have the reverse shoulder replacement. And by swapping the ball and socket around, what happens is you've changed the center of rotation. So now your center of rotation in the reverse implant would have moved more medially and would have moved inferiorly. What that does is it increases the length tension of the deltoid and gives it a longer fulcrum. So it's got a greater mechanical advantage. So the deltoid can now function like a cuff instead and restore your overhead movement. Now, we usually just quote that, it restores about at least 130 degrees. So you never guarantee full, but it's at least 130 degrees. And as you can see from subsequently my patients, actually with proper physio and rehab, they actually can get near full range of movement. Okay, but technically, external and internal rotations also need not have any significant gains following a reverse shoulder because it's not an anatomical procedure. Okay, but it does provide very good pain relief and restoration of overhead range of movement. So previously, the ideal patient would have been someone older than 70, low functional demands, because you're worried about the implant wearing if you had to put it in someone that was too young and someone who's very active. And of course, like I mentioned, you need a sufficient glenoid bone stock. And since this whole implant now is hinging on a functioning deltoid, so a working deltoid or intact axillary nerve was a must, But now there's all plenty of literature to show that none of these are requirements anymore. Now you can see that patients, younger than 65, younger than 55 is getting it done. Though I still would caution these are probably patients with, advanced serious shoulder conditions. It's not recommended for someone too young. I think 65 and older, it's a reasonable approach. Okay. And with regards to the insufficient glenoid bone stock, we now have techniques where either through bone grafting or doing custom-made implants, we can overcome the problem of insufficient glenoid bone stock. And to overcome the issue of, deltoid paresis or weakness, we now have other techniques where we can do muscle transfers, taking either the trapezius or the pec major to then kind of power the joint instead. Okay, so the clinical indications for reverse shoulder, it was first set up for cuff tear arthropathy. So that is arthritis like this as a result of a rotator cuff tear. So you can see because of the rotator cuff tear, the ball has now moved up in the socket and it's rubbing over the acromion and the top in the same both sides. And then you can see this is what we call acetabularization. So this is cuff tear arthropathy. And it did so well with cuff tear arthropathy that the indication just exploded. Okay, now I've done this procedure for all the indications listed here, but by and large, the commonest reason in our local population for having this procedure is usually one of the first four. Okay, aside from cuff tear arthropathy, it's also very useful for elderly patients with massive or irreparable cuff tears. In a younger patient with a cuff tear, you'd have to do a cuff repair, but that would require like 6 weeks in a sling and quite a long course of physio after that to kind of recover function. But with an older patient, especially with one with poor quality tendon that may not be amenable to repair, a reverse shoulder would allow immediate pain relief and near immediate restoration of range of movement. And I'll show you some examples later. Next, it's acute 3 and 4 part proximal humerus fractures in the elderly. As you know, osteoporotic fractures on the rise. Proximal humerus fractures are the third most common fractures in the elderly. And previously, if you have a surgery, whether it's open reduction internal fixation or hemiarthroplasty, you would worry about possible complications like non-union, malunion, avascular necrosis, glenoid wear, and implant complications, screw penetration, and need for revision surgery. Well, doing a reverse shoulder wouldn't have any of those complications at all. And, it gives you that reliable outcome and earlier, easier rehabilitation for these elderly patients. So I think it's quite beneficial for them as well. Number 4, revision arthroplasty. Well, what that means is the reverse shoulder is kind of become the salvage where for any kind of revision case, be it a failed fracture surgery scenario or failed anatomical or hemiarthroplasty scenario, the reverse shoulder will then be able to salvage it and reliably restore pain and pain relief and function again. And then we have rheumatoid arthritis. We don't see that so often here because I think our local doctors are doing a very good job and with medication. So I trained in the UK, and over there the rheumatoid arthritis, the cases were really quite bad and rampant, and it was not uncommon for patients to have multiple joint replacements done. But I think here with biologics and the medications, and maybe it's also the genetics, we don't see that severity. But in rheumatoid arthritis, together the degenerate bones, the tendons and the muscle quality may not be so good as well. So this implant would be very useful for those patients as well. Next, in primary arthritis, with or without some glenoid bone wear or a rotator cuff atrophy or tear, the reverse shoulder is also now gaining popularity instead. Because if one was to just do the normal anatomical shoulder, in the off chance that the cuff gives way over time, or if the glenoid, the wear was asymmetrical, it might be challenging to do it using the traditional implant. For the reverse, you can confidently and comfortably handle any of those problems. And then with tumors of the proximal humerus, after previously, we had limb salvage. So you'd have a prosthesis there and the patient would retain his arm, but he would have sacrificed all the muscles around the shoulder. And so it would be a flail arm and non-functioning. But now with the reverse, assuming his deltoid could be preserved, the patient could then have a functional arm, and that could, really lead to better quality of life. And finally, for fracture sequelae and various cuff deficiency situations, could be a untreated fracture, a malunion, a painful non-union. The reverse can still come in handy for patients like this. I'm just going to show you a case example of a patient that I did just slightly over 3 months ago. And this is just a very typical kind of result that you'd see following the reverse. Our patient is a 75-year-old Chinese lady. She's got a past medical history of high blood pressure and a previous right knee replacement. She's right hand dominant and she's very active. She enjoys dancing classes, goes for aqua aerobics, plays a bit of golf and tennis. She drives around, she's independent, and she looks after her hubby and her grandkids. So she presented to me with a bilateral shoulder pain and stiffness for many years. And prior to that, she had been seeing a rheumatologist, and he had diagnosed her as having bilateral frozen shoulders. And so she had a couple of HNL injections over the years and had tried multiple physios, but she still, was in quite a bit of pain. And even though she was still borderline, still able to do her ADLs independently, she was unable to enjoy her recreational activities like before. She wouldn't be told around and dance. And so she wanted to do something about it. So looking at her physical examination findings, you can see her range of movement is decreased symmetrically and slightly worse on the right. She had near zero external rotation and she wasn't getting overhead range of movement. And her cuff strength was symmetrical and her upper limb neurology was intact. Now these were her X-rays that actually her previous doctor had taken. Now it's quite tempting to label someone with a painful stiff shoulder as a frozen shoulder, but when you see an X-ray like that, with the decreased joint space, the osteophytes, the sclerosis, the flattened collapsed humeral head, this is arthritis and very advanced severe arthritis. In fact, it was so severe, the glenoid wear, that we couldn't just use a normal implant. We had to use a wedged implant with augments to take over that bit of bone loss. So this is the reverse shoulder. It was done. That's the wedge augment that's there, and that's just her 2 weeks post-op. So she was already doing it at 1 week. Actually, it's just that I took the video at 2 weeks, and she was back to driving. She had restarted all her classes after 2 weeks. So you can tell, even though she's got a mask on, she's really smiling from ear to ear and very happy with the result. And this was 3 months. So by 3 months, yeah, that's when she could get a full, sorry, let me get a full extension and reaching up back. So she hasn't done her left side yet, and I think she's probably giving it a good hard think about getting that done soon. So where are we now? All right. So the reverse has been around for like 30 years, like I said, and you can see there's a lot of evidence, from the 90s to now showing that, in terms of pain relief, patient satisfaction, the outcome scores, that there's significant improvements across the board. It restores a reliable range of movement. Like I say, I would say at least 130 degrees, if not more, with a proper physio regime. And for patient satisfaction, it does very well as well. In terms of survival, at 10 years, it's hitting about 93%. At 20 years, it's about 88%. And, the latest Australian registry showed that the total shoulders are performing as well as long as the total hips and the total hip knees. And those have always been classically regarded as the gold standard. And next, we have planning software and patient-specific instruments that let us position and plan how we implant the implants actually for more accurate positioning, so that you imply better kinematics and longer longevity of the implants. And yeah, this is something quite new and interesting, and I just got to do last month. Where we have, for severe bone loss, which previously would have been impossible to salvage. Now we can do 3D match reconstructions, where you can see plan out, you can see based on the 3D what's the defect that there is, and then you can plan out what the implant you would need to overcome the defect. You can plan the screw trajectories to make sure it's all in the bone and not like hitting air balls. And then we plan a prototype, and you have the final implant that lets you to do the surgery. So this is a case that I did just last month, actually. So the patient had a very significant post-traumatic wear from many years ago, and she was in a lot of pain and non-functional right arm, the dominant hand. She needed a mate to do everything. So you can see this is a 3D printed model of the defect, and this was the planning where we designed the implant she would need, the trajectory of the screws to get the best bone purchase. And then it's manufactured in the States, and they send it back to us. And so then we have a look at it. All right, so that's let's go back. So that's the bone loss. That's the jig that we use to drill into the best bone. And that's the model of the actual implant that will be there. And so then the actual implant gets sent to us. The whole process takes about 3 to 4 months. It has a name on it and everything. And it's plug and play. And then it made the surgery so much easier, and then now the patient has a painless arm that she can start to use again. So it's quite exciting where we're going these days with the shoulder replacements. So in our local experience, I would say in the last 5 years, the number of shoulder joint replacements being done has just increased dramatically, like 4 to 5 times. And previously a patient would stay for about 5 to 7 days. There'd be a drain and things like that. Now they usually just stay for one night. Like the patient in the video I showed you, they stay for one night, maybe 2 nights. And the average age of patients getting the shoulders replaced are getting younger. This is because I guess the implants are lasting longer. The patients are quite high demand nowadays, and they still want a better quality of life and function early. And the mean intra blood loss also is decreased, such that they don't need any transfusions post-op nowadays. And I guess you can ask, so why is this? How is this possible? How is this possible? Well, we now have newer surgical techniques and implant design, right? So you can see, like previously you would have a cemented long stem, and now the stems are cementless, and they come in like a mini, micro, nano, and even stemless design. So as you can imagine, so that's much more bone preserving, less invasive. There's less blood loss with that. And it's a platform system that allows for easier kind of switching between different implant designs. So, all this bodes for, less invasive surgery, less blood loss, shorter hospitalization stays, and faster recoveries. And, with the study into the tribology of stuff and all that, we have longer implant survival and overall better functional outcomes. So you can see the implants are getting better. The surgeons are getting better. You know, we train overseas in high volume centers and then we come back and bring the skills. So what else is left? I guess what's left is education. Okay, educating doctors like yourself so that you can advise your patients that there's a solution for their problem. You know, you don't need to just suffer in silence, and don't need to be afraid of you heard from your friend before that the outcome won't be good, or the stay was very long, or it's hospital for so long and it's very tough rehab. It's not like that at all. So that's one of the points of these kind of seminars. And then we also have to educate the patients. I guess we educate the patients through the mainstream media, through health magazines, so that they seeing other people's stories and success stories, then they realize that hey, that's me, and maybe I should get something done and looked at it. And the last thing is, I guess we have to educate the doctors and surgeons as well. So we have courses both locally and in the region, training surgeons from the region on how to put in these implants, how to get the most out of the implants, how to make the right clinical decisions for your patients, and generally all this is just so we can get better clinical outcomes for your patients. So to summarize, the reverse shoulder arthroplasty is here to stay, and it can potentially help a lot of patients with various pathologies. This graph here on the right, oops, this is the Australian Joint Registry, and you can see just over 10 years how much the incidence of procedures being done has exploded. And the same thing is mirrored across all these European and Asia-Pacific countries as well. And just in 10 years, how much increase in the reverse shoulder arthroplasty business has boomed. And as our understanding of the reverse shoulder biomechanics continues to evolve, we'll have further advances in the reverse shoulder design, we'll have better surgical techniques and superior clinical outcomes. See that picture there? I'm always telling my patients, I'm not happy till you give me a high five in the clinic. So that's what we strive to achieve with every case that I do. And I guess the final parting line is regarding shoulder arthropathy in the elderly, initial conservative management is always acceptable. Okay, the decision for surgery is ultimately based, I guess, on the patient's age, and it's not like the chronological age, but like the physiological age, their activity level and their demands and their expectations, and their existing medical conditions and their ability to follow post-op protocols. And the take-home, I guess, we all know is that the new techniques and implant designs allow for faster recovery, longer implant survival, and overall better functional outcomes. Okay, so with that, I have come to the end of my talk. Thanks everyone for listening. Good afternoon.